Good morning everyone. I am Dr. Saha, Senior Lecturer, Department of Microbiology, Boshundhara Atin Medical College. Today, I would like to invite you all the CME program on Antimicrobial Stewardship Program. And this will be presented by Dr. Hasiba Mahamuda, Assistant Professor, Current Charge, Department of Microbiology, Boshundhara Atin Medical College. At today's program, I would like to welcome our Honorable Chairperson, Professor Brigadier General, Retired Dr. Mohammad Ali Sir, Principal and Head of the Department of the Community Medicine, Boshundhara Atin Medical College. Co-Chairperson, Professor Dr. ABM Omar Farooq Sir, Vice Principal and Head of the Department of Anatomy, Boshundhara Atin Medical College. Special guest, Professor Dr. Mohammad Nurul Alam Sir, Ex-Principal and Project Director, Boshundhara Atin Medical College. Our Honorable Chairperson, Professor Brigadier General Dr. Mohammad Ali Sir is busy in official work. With his permission, we continue our program. I am going to request our program speaker, Dr. Hasiba Mahamuda, to make her presentation on stage.
Thank you, Dr. Shamoli, for giving me the floor. Assalamu alaikum, everyone. I am Dr. Hasiba Mahamuda, Assistant Professor, Current Charge, Department of Microbiology, Boshundhara Atin Medical College. Today we are here for another CME session, and it's a turn of our Microbiology Department. On behalf of my department, I am going to present today's presentation. The topic of my presentation is Antibiotic Stewardship Program. Stewardship, the careful and responsible management of something assigned to someone's care. In this picture, we can see a boy, little boy, is taking care of a plant, little plant, so that one day it can become a larger one. He will do everything and take care of the tree. So in this care, the tree is under the care of the child. This care and supervision is termed as stewardship. Now, antimicrobial stewardship. The careful and responsible management of antibiotic use is termed as antimicrobial stewardship. According to CDC, Centers for Disease Control and Prevention, antimicrobial stewardship refers to the use of the right antibiotic for the right patient at the right time with right dose, right route, frequency, which causes least harm to the patient as well as the future patients as well. Antibiotic stewardship doesn't mean that we will not use antibiotic. It only means that it ensures the identification of that small group of population or small group of patient who really need antibiotic therapy. On the other hand, there will be explanation and reassurance and education of the large group of patient will be given who actually don't need any antibiotic therapy. History. We all know that penicillin was the first antibiotic invented by Sir Alexander Fleming in 1928. But unfortunately, after the year of 1940, there was a development of resistance against that penicillin. In 1945 and 26, and at the time of Second World War, actually there was a breeding out of the penicillin first organism, which was really unusual, and indiscriminate use of penicillin actually gave rise to this resistant situation, which was really alarming for us, and still it's ongoing. In 1996, McGowan and Redding first published a paper on this, which showed an association between the use of antimicrobial agent and resistance, with the relationship was causal relationship, and the best method to prevent and control drug resistance is to ensure a proper antimicrobial stewardship program, which will include the proper antimicrobial selection, dose, duration of treatment, and should be a part of every antimicrobial treatment decision. In 1997, Society for Healthcare Epidemiology of America and Infectious Disease Society of America published guidelines on antimicrobial resistance. In 2014, the CDC recommended that all US hospitals should have an antimicrobial stewardship program. Now the question is it logical to use stewardship only with antimicrobials, not with other medicines? The answer will be yes. This is logical because antimicrobials are not like other drugs. If the antimicrobials are used inappropriately, they will not only have impact on that patient, it will lead to treatment failure, but it has also consequences on the broader society. A wrong prescription can lead to drug-resistant organism which can be spread from one patient to another in the same hospital, in another hospital, from hospital to the community, from community to the country, even across the countries. So you can see that use of antimicrobials should be done with very care because it has impact not only that patient but also to the broader society and throughout the country and as well as the future patients, which we do not, so stewardship is not needed in case of other medicine because that medicines are confined to that patient only, but antimicrobial is spreading in nature and affect the future generation. That's why we will need stewardship program only for antimicrobials. Now, why antimicrobial stewardship is needed? To prevent and control the antimicrobial resistance, spread of multi-drug resistance organism, misuse and overuse of antimicrobials. There is to prevent the widespread use of antimicrobials in other sectors as well as to establish antimicrobial research for newer antibiotics. Antibiotic resistance. Here we can see the two petri dishes. The antimicrobial susceptibility test has been done, and in the left hand side we can see this organism is susceptible to all available antibiotics. So it is a sensitive bacteria, and this is petri dish showing the growth of an organism which is resistant to all category of antibiotics. So this is a plate showing the growth of a resistant organism. Here we can see the mechanism of antibiotic resistance. In the first picture to last picture we can see there are resistant bacteria present. After use of antimicrobials, the sensitive bacteria are killed, but one resistant bacteria is there which got multiplied and it transfers this resistant gene to another sensitive bacteria, thus spreading the resistance. Here, horizontal transfer of antibiotic resistant gene from one bacteria to another occurs in these following methods. Transformation through naked DNA, in conjugation the suffix pili, the transmit is transferred, in transduction the virus carries the resistant gene to the bacteria, and membrane vesicle fusion. These are the methods of horizontal transfer of resistant gene. The mechanism, there are different mechanisms of antibiotic resistance. There is causes are decreased uptake of antimicrobials into the bacteria. There can be target alterations such as alteration in the binding protein in the nucleic acid or inactivating enzyme produced by the bacteria such as beta-lactamase, and there is efflux pump activation. How antibiotic resistance spreads? Antibiotics are not only used in case of human but also widely is used in case of livestock. These animals is a good source of drug resistant bacteria through their excreta as well as through their other products, and thus spread the antibiotic resistant bacteria to human. On the other hand, this human carries the drug resistant organism in their gut. He will be a good source of drug resistant bacteria to his community, as well as when he comes to the healthcare setting, it is also a source of drug resistant bacteria. So in this way we can see that the livestock as well as the humans, through these ways the antibiotic resistance is spreading all over the nature or environment. What are the causes of antimicrobial resistance? Causes are use of substandard antibiotics, self-medication, drug misuse, overuse of antibiotics in livestock, fish farming, etc., lack of sanitation and hygiene. There is over-prescription of antibiotics, very, very important. Patient not finishing their treatment properly, inadequate infection management of our hospital setting and environment as well, lack of new antibiotics being developed. These are the causes main. Here is a timeline showing the time of discovery of different antibiotics and development of resistance against these antibiotics. In this picture we show the first antibiotic was penicillin, which was invented in 1928. Development of resistance developed within a very short time. Within 12 years we can see that 1940 penicillin resistance developed. And on the other hand, we can see development of carbapenem in 1985, but unfortunately resistance developed in 1993. So from this picture we can see that the time duration of invention of an antibiotic and development of resistance is getting narrower day by day. And in last 30 years we have no new antibiotic discovered. So we have to be aware, it's high time to be aware the use of antibiotics. Otherwise our existence are in great threat. At present, all over the world, 7 million people are dying as a result of antibiotic-resistant bacteria all over the world. If this present situation continues, it may rise to 10 million per year by the year 2050. And at that time, every 3 seconds, 1 people can die just due to complication of drug-resistant bacteria. And this there is no time to compromise. It's high time to be aware, to be careful. And already there has been reports of pan-resistant pathogen. That means bacteria that are resistant to all available categories of antibiotics. And if this present situation continues like that, it is not far that we will enter into a post-antibiotic era, where there will be no single antibiotic in our hand. So we must preserve these limited antibiotics which are in our hand now. We have to take care of them. Misuse and overuse of antimicrobials. Now the antimicrobial resistance situation in Bangladesh, this is the overall situation at present. E. coli 60% it was showing resistance to ciprofloxacin, ceftriaxone, ceftriaxone. In case of Pseudomonas, 50% resistant to natilmycin, ciprofloxacin. This is the current situation of Bangladesh. Now, how to combat antimicrobial resistance? It's a 3-pillar approach. At first, we have to optimize the limited existing antimicrobial agent. Then we have to prevent the spread of infection by proper infection control mechanism. And we have to ensure the environmental decontamination also. Antimicrobial stewardship program has 3 objectives and 4 goals. The objectives are to achieve best clinical outcomes by minimizing the toxicity and adverse effect of drugs, to limit the selective pressure on bacterial population, to minimize the antibiotic resistant rate, to reduce the excessive cost. And our goals are to improve patient outcome, improve patient safety by minimizing the adverse reaction of antimicrobials, and to reduce the antimicrobial resistance, prolonging the life of our existing antimicrobials, and as well as reduction of healthcare cost. These are the objectives and goals of our antimicrobial stewardship program. Now, how to implement an antimicrobial stewardship program? First, straight up of structure and organization. Antimicrobial stewardship committee will include a lead physician of the hospital setting, clinical microbiologist, clinical pharmacist. Any interested clinician can participate in this committee, and specialist nurse involved in infection control program. Then 2 core strategies. There will be 2 core strategies of antimicrobial stewardship program. The front-end strategy will be made available through approval process. Strategies will be taken in the approval process, formulary restriction, pre-authorization of that drug, and in back-end strategy there will be the review method after the initiation of antimicrobial therapy, prospective audit, intervention and feedback. In the front-end strategy, drugs can be classified into these categories. The restricted drugs will need prior approval from the stewardship team minimum 1 day before supply. Semi-restricted drug will require approval more than 3 days supply, and non-restricted drugs will not need any prior approval from the antimicrobial stewardship team. It looks so attractive, but implementation may also be good, but it's really challenging, because if we categorize these drugs like this, our clinicians will lose their freedom to choose antibiotic. That's why practically it is actually creates confusion. But in back-end strategy, it's the antimicrobial review method. We have something to do here, because it includes the post-prescription review method. After prescription of antibiotic, review methods are done. It is difficult to perform, but it is effective. Its advantages are it is most widely practiced, more easily accepted by the clinician. So it is more feasible for us. High opportunity for education and training. Impact is delayed but sustained. So back-end strategy, we have something to do here, because it is practical. The back-end strategy includes the some following checklist. It will include such as review of indication, antibiotic, compliance with the guideline, whether appropriate antibiotic is chosen or not, proper drug, dose, duration. There will be review of the drug allergy. There will be review of selection of proper therapy after getting the culture sensitivity report. Review of conversion of IV to oral drug, it is maintained or not, etc. And empirical review of empirical directed therapy, which will based on biomarkers. These are the commonly used checklist. This is it is a questionnaire for antimicrobial stewardship program audit. This form will be filled up at the time of prescribing, and review will after the initiation of antibiotic therapy, review will be done, and this form and this documentation is necessary, and after that the stewardship committee will send this form, feedback form, to the corresponding prescriber. This is an sample of which is used in implementing in Apollo Imperial Hospital, Chittagong. Now, antimicrobial prescribing policy or guideline, which should include the definition of infections clearly. What is UTI, what is respiratory infection, etc. In which situation antibiotic is indicated, there will be clearly written which antibiotic should be given empirically. It will also be mentioned, which will be based on local antibiogram of that particular hospital. Escalation or de-escalation? Escalation or de-escalation. What is de-escalation? De-escalation is the withdrawal of drug after getting the withdrawal of drug from the empirical therapy after getting the culture sensitivity report. It's very, very important, as empirical therapy are widely used. So after getting the culture sensitivity report, the review method is very important to ensure that whether appropriate de-escalation or escalation is doing or not. There is shifting from parent to oral therapy, and when to discontinue, a duration should be clearly mentioned. This is a culture sensitivity report, an example showing resistance and sensitivities to antibiotics. And this is a local antibiogram based on a specific hospital or specific setting. Now, the antibiotic stewardship actually means the start smart, then focus. At first, without indication of infection, no antibiotic should be used, and there should be mention of a history of allergy. And there will be start smart, then we have to smart, and after that 48 to 72 hours already the culture sensitivity samples for culture sensitivity has been sent to the laboratory, and after 48 to 72 hours of initiation of therapy, second sample will be sent to the lab to see then whether the bacteria are getting resistant while doing treatment or not. And in case of after getting the sensitivity report, stop the antibiotic if there is no evidence of infection. Switch antibiotic from intravenous to oral, change of antibiotics to narrow spectrum or according to the culture sensitivity report, and outpatient referral for outpatient antibiotic therapy, and continue and document next review and stop the date. This is the surgical prophylaxis algorithm. In clean surgery, there will be no antibiotic is needed. In case of staph infection, according to local guidelines, treatment will be given to the patient. And in case of clean surgery with placement of the implants or clean contaminated surgery on contaminated surgery, surgical prophylaxis must be done by 1 dose prophylaxis at least 60 minutes before the surgical procedure. And if the surgical procedure is prolonged or there is excessive blood loss, so we have to ensure that redosing during intraoperative period should be done. Minimum requirements for the program are, we can see, we already mentioned that, multiple antimicrobial stewardship team, institutional guidelines, additional intervention to improve the use of measure and monitor antibiotic use, as well as periodic distribution of antibiogram. 3 main steps are there in stewardship. At first, to prepare guidelines for common type of infections. There will be surveillance to observe whether patients are being treated as per guideline or not, and feedback will also be given by discussing with the respective physician in case of non-compliance cases, and there will be training as well. Work distribution of antimicrobial stewardship committee are the development of antibiogram by the microbiology department, guidelines will be given by the clinical team, auditing by the surveillance team, and stewardship committee will give the feedback, intervention, and annual antibiotic consumption. The rational use of antibiotics. Antibiotic use checklist. Identification of bacterial infection. We just will not start the antibiotic at first without knowing that whether infection is there or not. We have to maintain some protocol. We have to see the blood markers as well. It's a CBC, CRP, procalcitonin. If it is more than 0.5, we have to confirm whether it is bacterial infection or not. We have to guess about the possible pathogen can be, and empirical therapy will be based on the local antibiogram of that particular hospital setting. And we can also have to have knowledge that there may be reestablishment of the normal flora. Host-age factors must be in our mind before prescription, and de-escalation must be done within 3 days. Last but not the least, growth of bacteria or fungus in culture plate doesn't mean infection. We have to differentiate it whether it is infection, colonization, or contamination by simple gram staining and as well as clinical features. So there should have a good interaction between the microbiologists with the clinicians. Then this program will be effective. Then site-specific antimicrobial. Knowledge about site-specific antimicrobials is mandatory for this. We can see some sites here and subsamples, and these antibiotics are not effective in this. We have to have proper idea about that. Such as in case of CNS infection, we cannot give the colistin and polymyxin B. This type of, we have to. Then examples of inappropriate use of antibiotic. Over spectrum. Such as there is the infection of the gram-negative bacteria. We can only use one kind of antibiotic, but if we use double coverage such as meropenem and piperacillin, both give the gram-negative coverage. It's an example of overlapping spectra. It's not needed actually. It's inappropriate. Redundant. In case of suspected gram-negative or anaerobic sepsis, we can use only meropenem or metronidazole. If we use both two, it will termed as redundant antibiotic, which is an inappropriate use. An ineffective antibiotic. This is example, as for example, methicillin resistant Staph aureus. Here methicillin is resistant, but we are using cloxacillin. So it's an example of ineffective antibiotic. And inferior antibiotic. In case of methicillin sensitive Staph aureus, if we use vancomycin, which is our reserve drug, which it is termed as inferiority antibiotic, we have to keep the antibiotics reserved to our hand. We have to choose the first priority antibiotics, then choose the reserve or not. We will not use indiscriminately. It will create more resistance. Common examples of avoidable antibiotic misuse are this: inadequate dosing, inadequate expectoration. I already have mentioned that. These are the avoidable misuse which we should avoid. These are the golden rules of antimicrobial prescription. microbiology guide therapy where possible. Indication should be evidence-based. Narrow spectrum drug is required actually. Dose should be site-specific, the duration, minimize the duration, as well as we should ensure the monotherapy in most cases, not combinations. The knowledge about intrinsic resistance. We both clinicians and clinical microbiologists must have knowledge about intrinsic resistance of because if we don't know that, there will be therapeutic failure as well as due to antibiotic for this instant resistance. We have to have clear idea such as Proteus mirabilis, which is intrinsically resistant to colistin cefuroxime. Burkholderia cepacia is intrinsically resistant to colistin. We will not use, as a microbiologist, we will not use that disc in our antimicrobial susceptibility plate, and as a clinician, you should also know that we have used this kind of antibiotics in these infections. Now, some important points about use of antibiotics are those. Empirical broad spectrum therapy is continued for a long time. Some clinicians unfortunately using this broad spectrum antibiotic even after getting the culture sensitivity report. If the culture sensitivity report does not support, they should not continue, which is a previous wrong idea actually, that yes, we have started and we will continue like that. No. And duration of therapy should be minimal. Average is 5 to 7 day duration. In case of antimicrobial, if we use antimicrobial sensitive, we have given the antimicrobials to the patient, but after 3 to 4 days we should review and send the sample for repeat antimicrobial sensitivity testing, because some organisms also develop resistance during the course of treatment, such as Pseudomonas aeruginosa, Klebsiella, Enterobacter, etc. So our take home message is antibiotic resistance keep increasing worldwide, as we all seeing that we are very close to a post antibiotic era. Rational use of antibiotic can only save our existing antibiotics. Practice culture sensitivity, isolate specific pathogen, select specific antibiotic and treat only infection. It's high time to develop and implement antimicrobial stewardship program in hospital setting. Yearly updating of our local antibiogram is really necessary for all hospitals. These are the resources of information references which I have used today. Thank you everyone for your patient hearing. Thank you so much.
Thank you, Dr. Hasiba Mahamuda, for your valuable informative presentation. Now I am going to request our respected special guest, Professor Dr. Mohammad Nurul Alam sir, and our honorable guest, Professor Dr. Gaji Zakir Hossain sir and Professor Dr. Tarek Mahmood sir to come on stage and take their seats. Now it's time for our question and answer session. Feel free to do any question regarding this session.
See that we have time, we can send the samples for the blood markers to see the blood markers, CBC, CRP, procalcitonin, etc. In case of bacterial infections, the procalcitonin level is high. So in these markers we can use, and we also send the specimen sample for culture sensitivity at that time. At first, after admission of a patient, according to severity, we will treat the patient. If the patient is severe, we will start empirical therapy, but before using that, we will send the blood to see the markers, as well as send the necessary sample to the lab for culture sensitivity. And empirical therapy definitely will be based on local antibiogram. And in case of mild to moderate cases, if admitted to the hospital without sure that it is infection, we will not use antibiotic. At that time, we will send blood to see the blood markers, as we have already mentioned in my PowerPoint presentation, and we will send the specific sample for culture sensitivity. After getting the culture sensitivity report, if the patient who was mildly ill or moderately ill, if infection is referred to that, according to culture sensitivity report, we will start antibiotic therapy according to this. But if In case of severe patient also, we have get the culture sensitivity report and it is not corresponding with the empirical therapy. Definitely we have to de-escalate or escalate. According to de-escalation means that if we are using broad spectrum antibiotic and culture sensitivity is showing the sensitivity to narrow spectrum antibiotic, definitely we should de-escalate. We will withdraw the broad spectrum antibiotic and either add the narrow spectrum antibiotic or switch to the narrow spectrum antibiotic. And we have to memorize that during antibiotic therapy start, after the start of antibiotic therapy, though it according to the culture sensitivity report, 3 days, 48 to 72 hours after the initiation of antibiotic therapy, sample must be sent to the lab for repeat culture sensitivity, because some organism also develop resistance during the treatment therapy also, though it was sensitive before, but now it can develop resistance during treatment period. So repeat sample, and as you have mentioned that how many times, it actually depends on how severely ill the patient is and how many days he is staying in the hospital. It actually depends on that, but normally generally at first, and then after initiation of antibiotic therapy, after 48 to 72 hours we can send the samples to the lab. Yeah, definitely we have something to do, as because it is at first we have to control the use of antibiotics in the livestock.
Now I request our respected honorable guest, Professor Dr. Gazi Zakir Hossain sir, to share his valuable comments regarding our CME program.
Assalamu alaikum. Respected teachers, honorable chairperson, guest, lecturer, I welcome you all for this nice session. First of all, I thanks to the speaker for presenting elaborately the program, and congratulate the authority for continuing such a program. This program is clearly described by the presenter, and the presentation was very elaborate and very clear to everybody, and it was participated by the audience very finely. I thanks all for participating in such a program. I request the authority to continue such a program regularly. Thank you all.
ধন্যবাদ। প্রথমেই ধন্যবাদ জানাচ্ছি স্পিকারকে সুন্দর একটা প্রেজেন্টেশনের জন্য, এবং মাইক্রোবায়োলজি বিভাগকে যারা এই সিএমইটা অর্গানাইজ করেছেন। একটা স্লাইড আমি এখানে দেখলাম, যেটা হচ্ছে অ্যাপোলো ইম্পেরিয়াল হাসপাতালের, ওখানে মনে হয় আকরাম স্যার আছেন এখন, তাই না? আকরাম স্যার আমার ডিরেক্ট শিক্ষক ছিলেন, খুব শ্রদ্ধেয় মানুষ। তো এই ধরনের একটা ইনিশিয়েশন আমাদের দেশে শুরু হয়েছে, এটা খুব ভালো ব্যাপার। তো এই স্লাইডটা, জি, তো আমি একটু অ্যাড করি। প্রথম কথা হচ্ছে যে এই ধরনের ডেটা আসলে আমাদের দেশে পাওয়াটা খুব মুশকিল। আমাদের দেশে কেন মুশকিল সেটা আমি শেষ করব সেটা দিয়ে। আমি বাইরের কিছু ডেটা শেয়ার করি। যেমন ধরেন 2018-19 সালের দিকে আমেরিকাতে, ইউনাইটেড স্টেটসে ওনারা অ্যান্টিবায়োটিক প্রেসক্রাইব করেন হচ্ছে 26 কোটি প্রেসক্রিপশন দেন। তো সেটা ইউনাইটেড স্টেটসের মতো জায়গায়, যেখানে মানে অনেক বেশি স্ক্রিনিং করা হয়, সেখানেও 26 কোটি প্রেসক্রিপশন একটা সিঙ্গেল ইয়ারে আসে অ্যান্টিবায়োটিকের। তো এইটা অ্যাপ্রোপ্রিয়েটও হতে পারে, ইনঅ্যাপ্রোপ্রিয়েটও হতে পারে। তো সেই প্রশ্নেরও উত্তর আসলে খোঁজা হয়েছে। তো এটা 11-12 দিকে একটা স্টাডি আছে, সেখানে দেখা গেছে যে রেসপিরেটরি ট্র্যাক্ট সিমটমস, আমরা এক্স্যাক্টলি টার্মিনোলজিটা ব্যবহার করা মুশকিল, ফিভার আছে, কফ আছে, মেবি প্রোডাক্টিভ, মেবি নন প্রোডাক্টিভ, এরকম। তো রেসপিরেটরি ট্র্যাক্ট সিমটমস নিয়ে পেশেন্ট ডাক্তারকে কাছে দেখা করতে গেছে। এটা জিপি হতে পারে, ইমার্জেন্সি হতে পারে, ইনডোর হতে পারে। এই ক্ষেত্রে দেখা গেছে যে 77% ক্ষেত্রে আসলে অ্যান্টিবায়োটিক দেওয়া হয়েছে। এটা ইউনাইটেড স্টেটসেই দেওয়া হয়েছে। এটা পেডিয়াট্রিক্স হতে পারে, গাইনি হতে পারে, বাট রেসপিরেটরি ট্র্যাক্ট সিমটমস নিয়ে যখন গেছে তখন 77% টাইমস অ্যান্টিবায়োটিক দেওয়া হয়েছে। এখন এটা ঠিক ছিল না, ব্যাঠিক ছিল। এখন এটাকে আবার ওনারা প্রসপেক্টিভলি দেখছেন, যেই 77 ভাগকে আসলে অ্যান্টিবায়োটিক দেওয়া হয়েছিল, এই 77 ভাগের মধ্যে 64% ক্ষেত্রে দেখা গেছে যে আসলে এটা ইনঅ্যাপ্রোপ্রিয়েট ছিল। তো এইটুকু ডেটা আমাদের কাছে আছে। আমরা আমাদের দেশের প্রেক্ষাপটটা আমি একটু পরে বলতেছি। তাহলে ওখানে এই অবস্থা। এখন কথাটা যেটা আসে যে ডাক্তার সাহেবরা যে জানেন না তা তো না, আমরা জানি, ওনারাও জানেন, তাহলে কেন এইভাবে অ্যান্টিবায়োটিকটা দেওয়া হচ্ছে, পারসেপশনটা কি, এটা নিয়ে আরেকটা স্টাডি হয়েছে। তো স্টাডিতে দেখা গেছে যে অ্যারাউন্ড ধরেন একজন ডাক্তার তার চেম্বারে আছেন আর বাইরে হচ্ছে পেশেন্টরা আছেন। তো এখানে দেখা গেছে যে 44% ডক্টরস মনে করতেছে, ওনাদের পারসেপশন, যে পেশেন্টের যদি জ্বর থাকে বা সিমটমস থাকে তো রুগী অ্যান্টিবায়োটিক চাচ্ছে আমার কাছে। দিস ইজ দ্য পারসেপশন অফ দ্য ডক্টরস। অন দ্য আদার হ্যান্ড একই কার্টেনের উল্টা পাশে যখন রুগীদের কাছে একই কোশ্চেনগুলি করা হয়েছে, দেখা গেছে রুগীদের মধ্যে 26% মনে করতেছে অসুখের জন্য হয়তো বা অ্যান্টিবায়োটিক লাগতে পারে। তো ফলে এখানে একটা পারসেপশনেরও ইয়ে আছে। তো ফলে এটা এমন একটা সিনারিওর কথা আমরা বলতেছি যেটাকে আমরা অলমোস্ট আইডিয়াল মনে করি, আর এবং যেখানে অনেক বেশি স্ট্রাকচারালি চিকিৎসা দেওয়া হয়। আর আমাদের দেশটা তো একটু ভিন্ন ধরনের। কেন ভিন্ন সেটা একটু বলি। এটা আমার একদম রিসেন্ট অভিজ্ঞতা, ইনফ্যাক্ট গতকালেরই। তো একজন পেশেন্ট আসছেন, ওনার ফিভার আছে অথবা নাই এরকম একটা কিছু হবে। এখন ওনার অ্যান্টিবায়োটিকের হিস্ট্রিটা শুধু বলি। উনি আগস্টের 28 তারিখ থেকে অ্যান্টিবায়োটিক খেতে শুরু করেছেন। অ্যাজিথ্রোমাইসিন খাচ্ছেন 500 মিলিগ্রাম করে দিনে 2 বার, 28, 29, 30, 31, 5 দিন খেয়েছেন। একদিন গ্যাপ দিয়েছেন, ওই জন্য ওনার ভালো লাগছিল। তো ভালো লাগার পর উনি একদিন গ্যাপ দিয়েছেন, এটা হচ্ছে রবিবার। সোমবার আবার 2টা খাইছেন, মঙ্গলবার আবার 2টা খাইছেন, বুধবার একটা খাইয়ে ওনার মনে হয়েছে এটা তো কাজ করতেছে না, খায় লাভ কি। তো এর ভিতরে উনি 15টা অ্যাজিথ্রোমাইসিন খাইছেন। তো 15টা অ্যাজিথ্রোমাইসিন কিন্তু যথেষ্ট শক্তিশালী জিনিস। এখন শুক্রবার ওনার মনে হয়েছে যে মানে এবার বোধহয় একজন ডাক্তার দেখানো দরকার। সো কাইন্ড অফ লাইক দ্যাট, যে এরকম। ফলে আমাদের একটা বেশ বড় সড়ো স্বাধীনতা আছে ওষুধ খাওয়ার ক্ষেত্রে, ওষুধ ইসের ক্ষেত্রে। তো আমরা প্রায় সময়ই দেখি যে পেট খারাপ কয় দিনের, 4 দিনের। কী ওষুধ খেয়েছেন, প্রথমে সিপ্রো খাইছি, স্যার কাজ করে না, পরে মেট্রো খাইছি, কাজ করে না, জক্স খাইলাম, এখন অ্যাজিথ্রো খাই আপনার কাছে আসছি। তো সেটা ভালো কাজই হয়েছে। কিন্তু আমরা আবার এটাও জানি যে মানে ডায়রিয়ার ক্ষেত্রে 95% কজে আসলে ভাইরাল ইনফেকশন দিয়ে হয়। আবার কিছু অন্য সিচুয়েশনও আছে, যেমন যারা অপারেটিভ প্রসিজিওরের সাথে জড়িত, গাইনি বিভাগ আছে, সার্জারি আছে, ইএনটি, অন্যান্য যারা, ইনাদের ক্ষেত্রে আমরা যে অনেক সময় মানে একদম আইডিয়াল সেটিংসের অ্যান্টিবায়োটিকটা ব্যবহার করতে চাই, তো সেই ক্ষেত্রে হয়তো বা ওনাদের অনেক সময় আপত্তি থাকবে যে আমাদের সেটিংসটা তো আইডিয়াল না। তো ফলে এরকম। তো এখন আমরা কি আসলে কিছুই করব না? আমার মনে হয় এটাও না, আমাদের আসলে বলতে থাকতে হয়। বলতে থাকলে কি উপকার হয়, একটা উদাহরণ দিয়ে আমি শেষ করি। যেমন ধরেন আমাদের দেশে যখন আজকের থেকে 5 বছর আগে, 10 বছর আগে আমাদের যখন ডেঙ্গু হলো, তো মানে আমাদের কিন্তু 1.5 লাখের নিচে নামলেই আমাদের একটু প্রেশার পড়তো যে কেন কমলো, কেন প্ল্যাটলেট দেওয়া হচ্ছে না। আমরা কমাতে আনলাম যে না ঠিক আছে 1 লাখে। আমরা কিন্তু তখনও WHO গাইডলাইন জানি না যে তা কিন্তু না, দেশের সব ডাক্তারই জানে মোটামুটি। এবং কিন্তু আমরা দেখা যেত 1 লাখের নিচে নামলে আর ধরে রাখতে পারতাম না, যে কারণ শুধু পেশেন্ট তো একলা না, তার সাথে আরও অনেকে আছে। তারপরে কি হলো, আস্তে আস্তে বলতে এখন 50,000-এ কিছু হয় না। এখন আমরা বলতে যেটা হচ্ছে যে দেখেন WHO শর্তটা কি, যে আপনার 10,000-এর নিচে আসতে হবে এবং অ্যাক্টিভ ব্লিডিং থাকতে হবে। কারণ প্ল্যাটলেট তো শরীরে কোনো অ্যাক্টিভ অংশ না, এটা ব্লিডিং না হলে কাজ করে না, আদারওয়াইজ এই বিলিয়নস অফ প্ল্যাটলেট তৈরি হয় এবং ডেস্ট্রয়েড হয়ে যায়। তো ফলে এই যে আমরা বলতে শুরু করছি, আমরা হয়তো বা 10 বছর ধরে বলতেছি, 20 বছর ধরে বলছি, কিন্তু পেশেন্টরা কিন্তু বুঝতে শুরু করছে এবং আউটকাম বেটার হচ্ছে আসলে। তো এটা অত্যন্ত ভালো উদ্যোগ। আমরা যদি সবাই মিলে চেষ্টা করতে থাকি, তাহলে এক সময় হয়তোবা আমরাও কিছু একটা ব্যবস্থা তৈরি করতে পারবো আমাদের দেশের মতো করে। সবাইকে ধন্যবাদ।
আসলে আমি যে কথা বলার জন্য স্টেজে উঠে আসলাম সেটা হচ্ছে অ্যান্টিবায়োটিক্সের সাথে আমাদের 5th ইয়ারের বেশ একটা অংশ ওতপ্রোতভাবে জড়িত। এই সেশনটাতে আমাদের 5th ইয়ারকে রাখলে আমার মনে হয় ওদের উপকার হতো। এটা যদি একটু মানে যেই সাবজেক্টগুলো যে ক্লিনিক্যালের সাথে জড়িত, এইটা আমাদের স্টুডেন্টদেরকে অনেক হেল্প করবে, একটু যদি অথরিটি চিন্তা করে। আচ্ছা, এটা গেল আসলে মেইন ইস্যু। আর অ্যান্টিবায়োটিক সম্বন্ধে আসলে তারিক খুব সুন্দর করে বলেছেন ডক্টর তারিক। তো আমি আসলে শুধু একটু যোগ করতে চাই, আসলে মানুষের পরিবর্তন হয়েছে। আমরা জানি পেডিয়াট্রিক্স গ্রুপে 95% হচ্ছে আন্ডার 5 ইয়ার্সে ভাইরাল কজ, আফটার 5 ইয়ার্স ব্যাকটেরিয়াল কজ ইজ মোর প্রিডমিনেন্ট। কিন্তু ভাইরাল কজের মধ্যে আমরা সবাই অ্যান্টিবায়োটিক দিয়ে দিই। হ্যাঁ, কিছু মানে পেশেন্টরা তো বলতেই থাকে যে ম্যাডাম অ্যান্টিবায়োটিক একটা দিলেন না। পরে আমাকে যখন আমি এক্সপ্লেন করি যে এটা তো অ্যান্টিবায়োটিক কাজ করে ব্যাকটেরিয়ার ক্ষেত্রে, ভাইরাসের ক্ষেত্রে কোনো কাজ করে না। এখন কিন্তু কিছু ট্রেন চলে আসছে, ম্যাডাম অ্যান্টিবায়োটিক যাতে না লাগে সেই ব্যবস্থা করে। এখন এই ট্রেন চলে আসছে, যদিও পার্সেন্টেজ খুব কম। তারপরে হচ্ছে আমাদের দেখা যাচ্ছে একটা ইনিশিয়ালি আমরা অনেক ইউটিআই পেশেন্ট পাই, অনেক সেপ্টিসেমিয়া পেশেন্ট পাই, শুরু হচ্ছে কিন্তু তার মাল্টি ড্রাগ রেজিস্ট্যান্ট, সে কখনো এক্সপোজ হয়নি। পেশেন্ট এভাবে বলে আমার বাচ্চা তো কখনো অ্যান্টিবায়োটিকও খায়নি, তো এত ড্রাগ রেজিস্ট্যান্ট কেন? আসলে আমাদের তো সব জায়গাতেই মানে কষাস হতে হবে। যেমন আমরা যেসব আমাদের পোলট্রি ফার্মে বা আমাদের ইয়েতে ক্যাটেলে যেসব অ্যান্টিবায়োটিকগুলো মিসইউজ করি সেগুলোকে প্রিভেন্ট করতে হবে। এগুলো প্রিভেন্ট করলে তবেই কিন্তু আমরা একটা অ্যান্টিবায়োটিক রেজিস্ট্যান্টের চান্সটা অনেক কমে যাবে। আমরা কিন্তু ওভার 1 ডিকেটের উপরও একটা অ্যান্টিবায়োটিক, নতুন অ্যান্টিবায়োটিক পাই না, কিন্তু এর মধ্যে অনেক অ্যান্টিবায়োটিক আছে অলরেডি রেজিস্ট্যান্ট। আমার একটা স্টাডি ছিল মগবাজারে, তো ওখানে দেখা গেছে যে এনআইসিউতে মোস্ট অফ দ্য পেশেন্ট অ্যাচিনোটোব্যাক্টার, ক্লেপশিলা, সিউডোমোনাস এই ধরনের অর্গানিজম, মোস্ট অফ দ্য পেশেন্ট নর্মাল অ্যান্টিবায়োটিক অল আর রেজিস্ট্যান্ট। অনলি সেন্সিটিভ নিওফ্লক্সিন or ciprofloxacin আর অনলি সেন্সিটিভ টেজোব্যাক্টাম। এমনকি অনেক পেশেন্টকে দেখা গেছে যে গ্রাম নেগেটিভ অথচ মেরোপেন রেজিস্ট্যান্ট চলে আসছে। অতএব আমাদের আসলে অ্যান্টিবায়োটিকের ক্ষেত্রে মানে খুবই কষাস হতে হবে, বিশেষ করে যেগুলো ছোট নিউবর্ন তাদের কিন্তু মানে খুব অল্প সময়ের মধ্যে তারা খারাপ হয়ে যায়। এখন আমরা যদি অ্যাপ্রোপ্রিয়েট অ্যান্টিবায়োটিক দিচ্ছি, এটা রেসপন্স করতে করতে 2-3 দিন আমাদের সময় লাগবে, কিন্তু আমরা এই রেজিস্ট্যান্টটা বুঝে যদি অ্যান্টিবায়োটিক না দিই আর অ্যান্টিবায়োটিকের ব্যাপারে যদি আমরা কষাস না হই, যতই মারামারি করি না কেন পেশেন্ট কিন্তু ভালো হবে না। অতএব পেশেন্টকে আমাকে সুস্থ করতে গেলে অবশ্যই একটা অ্যান্টিবায়োটিকের প্রোটোকল থাকতে হবে এবং মাইক্রোবায়োলজির সাথে ক্লিনিশিয়ানদের একটা কোলাবোরেশন থাকতে হবে, যেটা আসলে কোনো হসপিটালেই নাই, খালি হাতে গোনা 2-4। অতএব এখন আমরা যদি এখনও সময় আছে, আমরা যদি ক্লিনিশিয়ানরা এবং হচ্ছে মাইক্রোবায়োলজিস্টরা একসাথে কাজ করতে পারি, ইনশাআল্লাহ ভবিষ্যৎটা আরও সুন্দর হবে। সবাইকে অনেক ধন্যবাদ আমাকে ফ্লোর দেওয়ার জন্য। আসসালামু আলাইকুম।
Bismillahirrahmanirrahim. Respected teachers and my dear students, this is very important things which is being discussed today. Antibiotic, when it was invented or discovered, that time it was known as the magic drug or magic bullet, as because this drug used to kill all the organisms at that time, and it did not develop the resistance at that time. And if you see the history of infection, diseases, epidemic, history of epidemic, you will see the most of the epidemics was caused by the bacteria. You see, it's the plague, diarrhea, recent the viral infection, corona. This is all epidemics are related to bacteria and viruses. So bacteria, they have got the very important characteristics. What is that characteristics? They can develop the resistance to anything, any bacteria, any antibiotic. And last 50 years, what happened? The antibiotics which were being produced earlier, that is persisting until now. No drug antibiotics is coming up. And last, as because the pharmaceutical companies, they go for their profit. They do not have the responsibility, social responsibility and national international responsibility. These antibiotics, new antibiotics should come to prevent the infection of diseases, but they are focused for the developing the anti-cancer drug for drugs, non-communicable disease causing diseases. They are responsible for developing the drugs for non-communicable diseases, especially diabetic, hypertension, and other anti-cancer drugs. Why? As because this is more profitable. So they are investing for these purposes. Now this antibiotics, why it is important? This is a timely seminar is presented today. Timely is very important for our survival. If we do not act now and we do not take any action now, we are going to face a dangerous period or dangerous era. What is that area? Millions of people will die. Millions of people will die by infection by drug resistance bacteria. So this is very important. And antibiotic stewardship program, it was started in America. And when I was in Saudi Arabia, I attended few courses of antibiotic stewardship program. They started about 10-15 years, 10 years before. What is it? This is antibiotic stewardship program. What is the? It is a concerted effort, as because many things are included in it. One is the microbiologist. They are a very important part. Infection control team of the hospital is a very important part. Physician is a very important part, and the pharmacist, very important part. Pharmacist, why? The pharmacists are key persons to make the antibiotic policy, making the antibiotic policy. Okay, and every hospital, they have the antibiotic policy. Every hospital, they have the infection control team and infection control policy. But in Bangladesh, what is happening? They don't have the infection control team. Many of the hospitals, only few hospitals, they have the infection control team. They have many hospitals, they do not have the antibiotic policy. What are the antibiotics we have to prescribe? Especially that means the empirical treatment. For empirical treatment, what drugs we'll use, that is not mentioned in our hospital. So what happens? The physicians, they use the antibiotics rampantly and different types of antibiotics, which is not necessary for the treatment of that purpose. Okay, so this is very important thing. And another thing is that very important part is the surveillance and monitoring. In our hospital, we don't have any surveillance and monitoring for anything. This is very important also. So antibiotic stewardship program, it's a comprehensive thing, That is why you have to have the microbiologist, you have to have the physicians, you have to have the pharmacist, pharmacology department, you have to have the infection control team and others. So this is very important. And another thing is that, very important thing is that we start the antibiotic, but we don't know the de-escalation. And this de-escalation is a very important part of antibiotic stewardship program. We do not practice it. I don't know the clinicians and physicians, they are practicing or not. De-escalation is a very important part. And when we have to de-escalate the drug, suppose we have started the drug giving and we have tried for 2 days and we have seen the patient is febrile or patient, the culture report has come negative. If 2 consecutive culture reports comes negative, that means the patient is out of danger or he is not having infection now. So you have to de-escalate the drug. Either you have to switch over to another drug, or that is an empirical treatment, or you have to stop the drug. So this is the very important part. We are not doing that. We are doing once we start the drug, we continue for 5 days or 7 days. It's not necessarily needed, as because when there is no symptoms of infection or septicemia or something like that, so you need not to continue the drug. thing is that if you continue the drug, what happens, the bacteria which is being already killed and eliminated, the other drugs become getting resistance to that drug. So other bacteria which is present in your body already, that is getting resistant to that drugs. So that may increase the resistance pattern. So this is very important few things. This is in our country is a very difficult subject, a very difficult subject to implement, as because our logistic support is not there. Our authority, they do not think of this is very important topics. This is very important. Importance of this antimicrobial stewardship program is very important. They do not understand it, as because they think that this investment is unnecessary, and but this is you have a very long-lasting impact on the society, on your country, on your in the society. So this is very important, but they do not understand. But the thing is that we have to continue to tell all these things to the authority, and we have to disseminate this we should share all these things with the authorities, so they become understand, and they can take interest in implementing in antibiotic stewardship program. Thank you very much. This was very well presented. I think it was very nicely presented. Slightly thing that it should have been a bit short, and only important things should have been told, as because in the seminar you cannot tell all the things. It should be slightly smaller in the presentation, and that's all. But it is well versed and well spoken. Thank you very much.